On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
Welcome to ACC.13. It's the third day here in San Francisco, and there's a lot of activity going on. I've got a great panel joining us again to talk about really the highlights this morning. Alan Taylor. Alan is Chief of Cardiology at Georgetown University and MedStar Heart Institute. Alan, you got a tough job here. This is a seasoned panel, so we're counting on you here. Athena Pappas. Athena is the Associate Professor of Medicine at Brown University and the Director of the Echo Lab at the Rhode Island Hospital. And Chris Cannon, known to all of you. Chris is Professor of Medicine at Harvard and the Editor-in-Chief of Cardiosource Science and Quality. Alan, it's good to have you here. So, Athena, let's start with you. There was a trial called ASTRONAUT, is that right? Tell me a little bit about that.
Well, ASTRONAUT looked at aliskiren, which is a direct renin inhibitor, to look at this sort of vulnerable period of heart failure patients in the first 6 months after hospitalization, to look both at cardiovascular death and readmission. So again, a hot topic. They looked at over 1,600 patients. Right. The majority of patients were outside the US, and the short answer is that there was really no difference. So it did not have an improvement in that combined endpoint. At 6 months, there was 25% patients with a combined endpoint in both groups, and at 1 year is about 36%. And interestingly, you know, it was a pretty sick group because 12% were dead at that first year. The other thing I think that's important is that this drug did have some side effects. So predictably, 20% increase in potassium hyperkalemia, 17% with acute renal injury, defined variously. And then the other important piece, I think, is that in diabetics, it seemed to do worse. So they had a worse outcome.
Chris, does this surprise you, this trial?
Well, it's a key problem because, you know, half the admissions on service you get are heart failure, and then they just keep coming back, and, you know, it's just a vexing problem. We heard also, I guess, good old digoxin reanalysis looks like it can help on the rehospitalization side of things. Some good data in slightly different population for eplerenone. And so starting to see some things. Unfortunately, aliskiren doesn't look like it was a help in this situation.
Okay, Alan, did you want to jump in on that?
Yeah, they were really well treated, you know, at baseline,
That's
all
true.
on the right therapies, and with that, what you really just saw was some excess risk, some hyperkalemia and so forth. So, you know, the good basic therapy, you know, all needed drugs, and this has had a high prevalence of beta blockers, ACE or ARB, and a lot of spironolactone or aldosterone antagonism really leads to really the best outcomes.
So maybe there's too much. We can't block it too much.
Too much of a good thing.
Too much. So, Alan, there were a couple of 2 or 3 trials on off-pump versus on-pump cabbage. Tell us a little bit about that.
Yeah, you know, we get this off-pump cabbage idea that it could improve outcomes.
Sure.
And lots of outcomes you could envision. Mortality, heart attack around the time of surgery, neurologic outcomes, length of stay, and so forth. So 2 trials, one the Germany off-pump coronary bypass evaluation, and then the coronary trial. And basically the short answer again is that they were both negative trials from the perspective of the overall cardiovascular outcomes, death, and so forth. But the nuances, I think, also help us. The coronary trial shows us that neurocognitive outcomes were the same. And that's been a hypothesis, that being off pump would preserve neurologic outcomes. Now, what they didn't tell us was if the patients most at risk had some benefit, those with mild cognitive impairment going in. It'd be nice to see those data. The Germany study gives us data on length of stay and ICU stays and so forth, which looked comparable as well. So there's an endpoint that we thought it might ease the hospital's length of stay, and it doesn't look like it accomplishes that. So overall, it looks like either one's an acceptable approach, whatever you're best at, similar outcomes, but we'd like to see some nuances from some of the important cognitive endpoints.
You think is this going to change practice at all?
Well, you know, I was at this session with a couple of surgeons, and the theme that came out was that in general it's trickier to do, but those who know how to do it would apply it to their highest risk patients. And so one group, for sure, if you have an identified calcified aorta that you don't want to cross-clamp and create a stroke. A third study was presented, a single center study, about 200 patients, so much smaller than the definitive studies. In that setting, they studied just people that were highest risk, so with a Euro score of greater than 6 or 7, which apparently is high risk. They found a benefit in their hands. And so that theme of if you do it well in the right high-risk patients, this may have some benefit, but in general, the standard on-pump seemed to be...
I think it's interesting. I wanted to go to Chris. Chris has another interesting study. Were you going to say something?
I was a little worried about the single center studies,
and
that
right.
But there are going to. We'd have to think that there could be some hypotheses that come out of this.
Definitely.
Some really high risk subsets.
I mean, that's what
mild cognitive impairment, calcified aortas, liver dysfunction, where the pump can be really dangerous.
Absolutely.
Some of those might be worth getting into in the future.
And, even at that center, they said they've backed off on how much off pump they're doing. So I think the conclusion seemed to be that there's a role for this in a small group, but not broadly.
If you have a really talented surgeon that does that, that's what they do. Chris, there was a study called MassCon, is that right? Tell me about that.
Yeah, so the Massachusetts Community Hospital look at elective PCI. Could it be done at sites without on-site cardiac surgery or not? Very well done, close to 4,000 patients, a 3-to-1 randomization of doing elective PCI on-site, with an important component being that these were community hospitals who really set up a program. They had to, each operator had to do 75 cases a year, had to do primary PCI at those hospitals, have a transfer protocol in place, be ABIM interventional cardiology certified. So the real thing, and so they had excellent outcomes and equivalent to doing it at hospitals with on-site surgery. And so I think this could have implications of where patients would have their elective PCI, already some primary PCIs being done in the community. If a community hospital gears up or partners with, and some of the interventionalists go to, the peripheral hospitals, that the outcomes look very good.
So Athena, did you want to?
Well, it's similar to Seaport, and I think before we extend it too much, the important piece is the ones you mentioned, and it's not for everybody. It's a very well-controlled, high-volume group, really. So I think that's a very important take-home message.
Well, I mean, all the criteria that Chris mentioned, that they set it up, it sounds very good.
Set it up right.
It comes down to patient selection. These are mostly single-vessel PCIs, really well-selected lesions, and I think that's a key component to patient selection. And the backdrop is, of course, they have to be appropriately performed. Yeah. And that's the big context that this all occurs within, dividing the work more centers, but they still have to be appropriately performed with an eye on quality.
Yeah.
Okay. Well, we've got a lot of great information. We're going to have a chance to come back. We're going to be back in just a minute. We want you to join us, so stay tuned and come back shortly.